slide. So it is the pancreas, which is the organ where we are looking at the different functions, endocrine and exocrine functions, and that is where the alpha beta cells are there, and the beta cells of islets, which are when it is not functioning or partially functioning, and then we develop different types of diabetes. Next slide, please. So here we look at the pancreas as an endocrine gland. And we know there are alpha cell which secrete glucagon, which are the main function is to raise blood glucose level. And whenever we know that when the blood glucose level go down, we give glucagon injection to those hypoglycemic patients to take the raise the blood glucose level. The beta cell secretes insulin and lowers blood glucose. These are basic, so I'll go a little faster. Then there is delta cell, which secrete pancreatic peptide, and these are the regulated digestive secretion for the motility. And we are aware of this physiology. And if you are not aware, I would want, I will emphasize that please mute all of you. Sir, Mr. Mute. All of you mute your mic, please. And it is mute the mics, Mr. Advait. All the other people, you please mute them. Vishaka, please mute all of them. So these are the few endocrine, few cells which are responsible, which we have seen the function. Even the ghrelin is secreted by the pancreas, and that is the orexigenic, the appetite hormone we call it. Next slide, please. Yes, so we come to a diabetes mellitus. It's a heterogeneous, complex metabolic disorder characterized by elevated blood glucose concentrations secondary to either resistance or to the action of insulin or to the insufficient insulin secretion, or maybe the both. We know this ADA definition very well, so I'm sure I don't need to explain this further. Next slide, please. Here is the different types of diabetes, like with normal physiology, the type 1 diabetes and type 2 diabetes. What happens is the glucose remains outside the cell because of insulin deficiency or insulin non-availability, absence of insulin. The type 1 is absence of insulin, and type 2 is the receptor is not there to take this glucose inside the cell, and therefore we get type 2 diabetes. Next, please. Next slide. Yes. So this is what is the insulin, the regulation of blood glucose by insulin. And this is how we know we have glucose production from liver, and we get whatever we eat gets digested, and we have glucose. And when there is a high blood glucose, the pancreas will secrete the insulin, and blood glucose will come down. And when there is low blood glucose, we know the glucagon secretes, and then the sugar is balanced. So this is a natural process of the controlling blood glucose levels. So the insulin, if there is a beta cell destruction or unavailability or absence of insulin, then we have different types of diabetes. Next slide, please. So this is just a classification. Diabetes, type 1 diabetes due to autoimmune beta cell destruction. Sometimes we do not know the reason for this, but then it is autoimmune beta cell destruction, usually leading to absolute deficiency of insulin, including latent autoimmune diabetes of adulthood, we call the LADA. Then the type 2 diabetes, we know progressively the loss of beta cell occurs, and the secretion day by day reduces, and that's how also we develop the insulin resistance. There is insulin, but the absence or not non-functioning receptors. The receptors are not there, so which take the cell take the glucose into the cell, and that's why the type 2 diabetes develop. Next, please. Next slide. Yes. So we will look specific types of diabetes due to other causes. Now there is a monogenic diabetes syndrome, which is neonatal diabetes. There is maturity onset diabetes of the young. These are called monogenic diabetes syndrome, MODY we call it, maturity onset diabetes of the young, and the neonatal diabetes. Then there is a disease of the pancreas, like cystic fibrosis and the pancreatitis. So we do get pancreatic diabetes. I mean, the terminology is not used, but these are the other causes of diabetes. Then there is a drug or chemical induced diabetes, which we all know, with the glucocorticoids and the immunosuppression drugs. So there isn't because of the when there is a treatment with HIV, AIDS, or chemo drugs, or any other drugs which are transplant patients also develop diabetes because of the immunosuppression drugs. And then there is TDM. We all know it's diagnosed during the second or third pregnancy, and not clearly overt diabetes prior to the gestation. That is another one. If it is already diabetes and pregnancy is different, but TDM develops in second or third pregnant trimester. Next, please. So here is the for dietitians. How do we look at these different diabetes, and how do we look at these different patients? This is because why I want to emphasize here the dietitians. That is we as a dietitians treat the symptoms of diabetes. We don't treat the diabetes as a disease, and that is where it comes for us to come assess the patients and come to the nutrition diagnosis, which is PES system, which is based on problem etiology and signs and symptoms, and the independent nutrition diagnosis, which you and I, as a medical nutrition therapist or diabetes educator, or if you are practicing dietitian, you will treat symptoms. So we treat patients symptom based. Also, we will see what medication is there, and we synchronize our meal pattern. But before we go into the detail, very important to have your nutrition diagnosis, which Geeta will further take in the screening. But when I was looking at this slide, I wanted to speak on these symptoms. Yes, so we were explaining about the different symptoms and what is the reason behind this symptom, which we need to tackle when we are tackling these patients. So this polyphagia, we all know that why does this happen? So when the glucose is not able to enter the cells are starving, and that is what is causing the hunger. So that's why the polyphagia occurs. The other reason is there is large amount of glucose in blood, which will also increase the osmolality. So these are the reasons which we need to see about every symptom the diabetic patient is undergoing, and what you as a nutritionist can do to take care of these symptoms. So then comes glucosuria. So why does there is glucose in the urine? So renal tubules are not absorbing the excess glucose, and that's why it is filtered by the glomeruli, and the glucosuria results. And then we know because of the high glucose in the bloodstream, there is polyuria and polydipsia. And because you are passing more urine, obviously you will have more thirst, and that is why the symptoms are there. Next, please. Next slide. Geeta, you are changing the slides. Can you? speak, yes. So there are other symptoms. We look at this, the earlier one, please. The vascular ones. Yes, the vascular changes. There is energy issues because of excessive hunger and because of the glucose loss in the urine, the glycosuria. We are also losing the energy. So we have deprived, the patient feels more hungry, fatigue, weakness, and there is a risk of diabetes, ketoacidosis for type 1 in the absence of insulin. The glucose is not entering the cell, and that's why the ketone bodies are coming. And then, of course, because of all these, weight loss is the symptom which the patients come with the weight loss with us because of the glucose loss in the urine. And there are frequent infection because of the glycosuria and because of the immunity going low, because your the blood glucose is very high, and we all know the organism, the bacteria, they thrive on the glucose, and that's how there is a frequent infections also. Yes, Geeta, can you speak?
So, ma'am, I think we were talking about the symptoms, and then we talked about other symptoms. And as you have already said, that talking to a patient is understanding patient's symptoms. We talk about symptomatic approach. For example, friends, if you have a patient in front of you, let's take a scenario that you have friends in the patient in front of you, and he's come with lot of challenges in his health. I think, next slide, please. I think that every dietitian needs to understand the pathophysiology. Now that you have understood well, as Salome ma'am has given us a brief overview of it, and when you know that, okay, this is diabetes mellitus, and I need to understand his symptoms better. So the first thing every dietitian should be doing is talking to a patient and asking probable questions, because patient wants to be heard. Give some time to the patient, listen to the patient, because as we go ahead, when you have a case in front of you, you will be able to know. When you know the patient complains of polydipsia, polyuria, or whatever it is, we have just discussed it, maybe few symptoms patient must have missed telling you. Because you know the symptoms, that is why it's very important to learn the pathophysiology, symptomatic, and the guidelines, cutoffs, etc., because then you will be able to make out what actually the patient wants to know, or what you have to highlight in his management. Next slide. So if your patient complains that I feel tired in between, I think it's our job to ask the patient, do you feel fatigued? Is there a hypoglycemia? Do you feel challenged? And then when you know and screen the patient from his A, B, C, D, and I think the probable questions, we need to be more interrogative to have a better medical nutrition management, because we are talking about non-communicable diseases. So age, because these are the risk factors which are highlighted in the ADA guidelines, where the risk factors which contributes to diabetes are age, previous impaired fasting glucose, maybe he was pre-diabetic for a long period of time, so you know that he's carrying a risk of pre-diabetes since a long period, hypertension, dyslipidemia, GDM in past history, family history, genetics, obesity, ethnicity, or whatever we are trying to look at, that how the risk factors contribute to the diabetes of his present status. Because, for example, next slide, please. For example, you have a patient who comes to you with type 1. I'll just give you a scenario, friends. I had a young boy other day, 17 years old, who came to actually he was type 2. He was overweight. He was 5 feet 10 inch, young boy, 17 years, gained 30 kgs of weight in this pandemic. He went into DKA. Doctor said, let's start. The C-peptide was done. It was more of type 2, but then he was started on insulin. Now that we know that there is an insulin, but the patient's C-peptide tell us that he's type 2. So autoimmune destruction is the basic challenge of type 1 diabetes. So we know that pathophysiologically type 1 is all about pancreatic islets which are infiltrated with lymphocytes. So we call this as insulitis. Now you know that in type 1, my beta cells are destroyed. There's an inflammation behind the scene. The autoimmune pancreatic beta cells actually gets destroyed, and that gives you insulin deficiency, secretion deficiency. So friends, when we know that it's an autoimmune, type 1 is autoimmune, is the inflammation challenge, is obesity or fat cells giving an inflammation? So end of the day, when I tell you this typical case of 17-year-old boy, type 2, but on insulin, do I have to understand that, okay, first I need to know his C-peptide levels. What are the symptoms of that patient? Next slide. And in that symptoms, what is my first addressal? Definitely if he's on insulin, next slide please. Definitely if he's on insulin, I need to know that hypoglycemia prevention is my first goal. If my hypoglycemia prevention is the first goal, but I know that patient is type 2 more than type 1, symptomatically, I need to interrogate and ask him, do you feel hungry? Do you feel thirsty? Do you want to eat volume of food? What was the main cause of your weight gain? Maybe the inactivity, maybe a lot of high glycemic load in his diet. The root cause of his diabetes needs to be addressed. And in such scenario, I think the pathophysiology for you will make it more easily. Is it easy to able to work on it? Is it autoimmune, inflammation, or it is simple obesity which is giving you inflammation and then a dyslipidemia or diabetes? So very simple way of looking at these areas, because in type 2 also, when you look at this slide, you'll be able to make out that the type 2 is all about insulin resistance, because you know that there is a decreased glucose uptake by your muscles, by your energy output, or the obesity, the environmental causes cause type 2 diabetes. Next slide. And then we have gestational diabetes. Gestational diabetes is nothing but a diabetes which is defined as glucose intolerance and detected in pregnancy. Ma'am, would you like to contribute here something?
Continue. You continue, Geeta.
Okay. So most of the women who develop GDM actually have the onset of this in third trimester of pregnancy, and they do get into a higher risk of type 2 diabetes going ahead. Friends, what's important is we are trying to highlight, next slide, we are trying to highlight here, when you try to identify your patient and you want to work on the patient's nutrition application, nutrition therapy, you have till now learned that it's very important to get into the pathophysiology, then understand the risk factors, the root cause, the trigger for that particular diabetes, and then learn to manage the diabetes management through the route where the patient has gone through. And that is why I think each one of us need to know the protocol, the guidelines of all the journey of that diabetes management, which makes our job easier when we try to counsel the patient or when we try to make a medical nutrition therapy. So we all know that protocol for investigation is for ANC is 2 times. Testing of GDM is recommended for 2 times. First, it should be done in first antenatal contact as early as possible whenever the patient visits the doctor. Nowadays, this OTT test is done always. Second test should be done, if it is negative, second test should be done 24 to 28 weeks of pregnancy. So there should be at least a 4-week gap between the 2 tests. This test, irrespective of whatever it is done for all pregnant women. So I think a dietitian, next slide, dietitian always needs to ask, is your OTT done? Though the patient is not potent, maybe not predisposed to diabetes, but still a GDM testing, now as you can see in this slide, is a mandatory for all pregnant women in the community. And they have latest papers from our Indian authors, Indian doctors, who are saying that testing for GDM in first antenatal visit should be with 2-hour plasma glucose, 75 gram of oral glucose. So when you have a GDM patient, first thing is ask for oral glucose tolerance test, then see whether positive, that is the postprandial glucose more than 140 milligram per dl, manage the GDM as per the guidelines. Negative, wait for it, but the patient should visit you every trimester, and at 24 to 28 weeks, you can always ask the patient to redo the test. Next slide. Because if the patient has missed it, and I think we are more of educators also here, we are educators where we need to highlight these areas which are very important. If patient has missed the testing, patient has missed going to the doctor, or patient has missed this important test which has to be done in pregnancy, I think a dietitian should be equipped with the knowledge that she should be able to tell patient that you are due for your test now. Please do your oral glucose tolerance test the second time in antenatal. It's important. Because the management of GDM is all about weight in pregnancy, and especially if you're predisposed to weight management. So these are the national guidelines of diagnosis and management, and they have taken 24.9 as normal weight. I've taken this from 2019 guidelines, national guidelines of diagnosis and management of GDM. And this is from Indian National Guideline. And they have taken, if you see, the BMI cutoff as 24.9. And then they have given the weight range. So I think the first point for a GDM of a dietitian to counsel is tell the patient about the weight which the patient can afford to gain in the pregnancy, in the gestation. So maybe a normal weight BMI, so conception weight is very important to highlight the BMI. Then check what is the total weight gain the patient can work on in the normal weight BMI. And accordingly, we will not go, you will find all this information on the website once you go there so that you can see these numbers there. The goal of today's discussion is what a dietitian should be interpreting through the patient's values, guide, and the knowledge of the guidelines, the cutoffs the dietitian should be having, so that she can speak to the patient and learn and educate the patient about the quantification of the weight gain, the carbohydrates, the MNTs, etc. Next slide. So what should be checked in GDM? Once the patient comes to you, yes, we need to know the weight. Conception weight, conception BMI, recommended weight gain, the blood sugar, OTT, as per the cutoff, we should know the cutoffs, and then we take the medical nutrition therapy ahead. Salome ma'am, I would like you to now tell us about what you feel a dietitian should be working on a GDM scenario.
So when the patient with GDM comes, so first of all, you will check what trimester, which trimester the patient has come. And then you will try to find out the preconception weight. Many times the female who come with GDM, they do not even know the
Can you hear me?
weight. I can hear you, I'm speaking, Geeta. So we must ask them, and at least if they don't remember, and if that is the first pregnancy, you ask them, what was your weight at the time of marriage, and did you put on the weight? So that as Dr. Geeta rightly said, the conception weight is very, very important. And then first 5 months, that is the first trimester, and the 2 more months, that is the 5 months, we are looking at weight gain.
Okay, so what to check in GDM is the slide which we were on, and I think Salome ma'am has given her inputs. And then we go to the next part of this discussion, and can we have the next slide? Can we have the next slide?
Yeah, it is there. Lifestyle management.
Yeah.
Glycemic target.
This we've already spoken. Next slide.
Okay.
So the holistic approach. So the MNT in GDM is about individualization. I'm sure we are in an area or a world of personalized nutrition where we want to work on individualized goals, glycemic goals. Because in GDM, friends, there is no specific recommendations of optimal intake. If I go in RDA, I will see a very vague way of looking at 80 grams of proteins, or some quantitative approach towards the calories, plus 300, 1700 plus 300. But I think that has not considered the conception weight, the calorie intake. So the 2021 journal which I have referred have said the DRI is 175 grams of carbohydrates, 71 grams of protein, and 28 grams of fiber. Now, the challenge is the protein intake in an Indian scenario with 71. We can always look at a good glycemic load of the patient rather than looking the quantitative approach of working on that particular 71 grams of protein, because I personally feel that giving so much of protein generally is not feasible. There are a lot of gastric issues, constipation, acidity, vegetarian diets. Then the carb intake is very high. There's a lot of cravings. So with these challenges in the patient, when he comes to me, it's very, very difficult. So we can always look at keeping a protein in every meal as 10 to 20 grams. 20-gram protein per meal with an adequate fiber in the diet will have a very good control on your overall glycemic load. So I think it's important that when you handle GDM, the quality of fat, the glycemic load, and an individualization of your calorie plan or nutrition plan is very, very important. Holistic approach. The next slide, please. So it's all about a holistic approach. The management of GDM, pre-GDM, I think is a collaborative effort between the endocrinologist, obstetrics, dietitian, educator, I feel. And what the patient needs at this point is more of a holistic approach. Education is what we are looking at. Salome ma'am, any inputs from your side? Anything you would like to comment on this holistic approach, your experience, please?
No, you are very right. It is a holistic approach, and that is where the nutritionist and nutritionist come diabetes educator has a very important role here to play that, and then coordinate with other team members so that we are on the right way.
Correct. So now, next slide, please. So now we look at, after GDM, the screening and diagnostic tools for type 2 diabetes, in pre-diabetes and type 2 diabetes. Because friends, the whole goal, as I've already said, is working to understand the overall approach towards any patient who comes to you with hyperglycemia. Pre-diabetes, type 2, type 1, GDM. What's important is personalization and understanding the pathophysiology to cut off. So as you can see on the screen, the HbA1c in pre-diabetics is 5.7 to 6.4 and diabetes is 6.5 above. Fasting is 100 to 125 and in diabetes above 126 milligram per DL. Postprandial is 140 to 199 and more than 200. Random blood glucose is more than 200. So now you're able to understand that the cutoffs are for pre-diabetes, fasting, A1C, PP are these. Suppose a patient is not come to you with a diagnosis of diabetes from the doctor, but you see his blood reports, or you feel that there's a lot of central obesity, there's a lot of visceral fat, which needs to be highlighted for insulin resistance. And I think it's dietitian's job where she can interpret, intervene, and talk to the patient saying that, why don't you also do a fasting sugar? Why don't you also do an HbA1c? Educate the patient about it, because she has a knowledge of what the guideline says for the cutoffs of all the diagnostics tests, which you can see on it. Next slide. So end of the day, I think education to learn, to work on what the cutoffs say, and accordingly, we have to start looking at interpretation of the patient's medical nutrition therapy. So the whole goal of this session is not just telling patient please eat this and do not eat this, do not avoid banana, chiku and all that. It's all about telling the patient smart eating with a controlled glycemic load, because you know that if your patient is pre-diabetic, the goal of the pre-diabetes is make the patient lose weight. And that's very important. Which weight? The central obesity. The central obesity says, okay, we need to work on the glycemic load of the meal if the patient is on a high carb diet, or if the patient is inactive, make the patient move. Very simple guidelines for pre-diabetes. Diabetes, work more on specific control and more stricter regime of the patient. Next slide. So again, the goal, the way we start looking at it is, am I aware of what I'm actually talking to the patient? If my patient comes to me with some kind of diabetic management diet plan, I also have to see other areas of the testing. Is the lipid, because when we know that patient is diabetic, we also have to consider lipids, renal function tests, urine microalbuminemia, or ECG, or any cardiac profile. Salome ma'am, would you like to add anything here? Any other tests, and how a dietitian should manage here?
No, this is enough. Yes.
Any other test, ma'am?
No. This is fine for MNT purpose.
Friends, you can always type what you want to say so that we can take those at the end of the discussion, because this is what we have thought about it, and we are trying to tell you the same thing. But if you feel that more tests can be added and any more inputs you would like to add through the counseling, through the guidelines, what more can we be into? So it will be help for other dietitians who are attending these sessions. The next slide. So the step 3, we've talked about step 1, the next slide, the step 2, and now the step 3. You've learned the patient's nature of diabetes. You've learned the environmental impact. You've learned the labs. Now you screen the patient for diet recall. Next slide. So then the diet recall. So friends, the patient cannot sit in front of you for a long period of time. This is your interpretation in a very quick way. You have to start planning in your mind when the patient comes to you, and your goal in diabetes is euglycemia. That's it. The euglycemia starts asking starts asking questions in your mind, that why does he have hyperglycemia? What is the reason? What the screening tells you? What does your knowledge about diabetes tells you? So your euglycemia comes with therapeutic goals and good counseling, listening skills. Next slide. So nutritional management goals. Next slide, please. The nutritional management goal says that learn about nutrition and nourishment to your patient, educate your patient about smart eating, look at the root cause of your diabetes. It can be weight, it can be insulin sensitivity, it can be inflammation. A post-COVID, if you have patient coming to you with diabetes, always say hyperglycemia. You know that, okay, it is a diabetes because of inflammation. This inflammation needs to be addressed first. So look at anti-inflammatory diet rather than giving lot of keto diet or this kind of no fibers and a typical weight loss diet, because the increased proteins in the diet may trigger the inflammation. So friends, I think the dietitian, next slide, the dietitian should be learning about what actually caused the insulin resistance or sensitivity. This is a very beautiful patient-centric glycemic management. You can download it. This is actually taken from our Indian guidelines of 2019 of goals of care. We must be aware that we have now the GDM guidelines, diabetic guidelines for Indian patients. So this is taken from that, and it is so beautifully written. What are the decision cycle for patient-centric? You keep your patient in the center and say, my first goal is improve his quality of life, and I want to prevent complication and give him euglycemia. Simple. Till now, what we have spoken, what we have understood, the screening part, the pathophysiology, education, counseling is more important. And I think the approach towards any diet management should be positive. More of what to eat than what not to eat. More of quantitative approach than a qualitative approach. Because today, in an era of where we can actually tell the patient that you know everything, then why do you come to me? Because he comes to you with a lot of learning. So then the topic comes is we want to know exactly what actually is right, what we know is right or wrong. Then you say, yes, you have come to me for personalization, because behind the scene as a dietitian, I have a lot of knowledge about everything from pathophysiology to the medical nutrition therapy, which no other fraternity has it. Food science is a big add-on knowledge for us, which we can actually work as a better. So friends, this was a very brief overview. Next slide. And now we take the case studies, where I would like Salome ma'am also to give her inputs. We have taken just one cases, and I will expect a lot of questions from your side, so that it's more of discussion and more of talking about what we have today discussed with you is on the lines which you want to learn, because the goal of this BNA Live is education, working on application. So let's start with the case study. A simple case study I thought I have taken, and which will be able, next time, as Salome ma'am said, you can give your inputs, what you want to hear from us, what case-based discussion, we will take it from there. So since we did GDM today, we did type 2, we didn't do a lot of type 1. I thought type 2 case can be a better fit in this. So a 35-year-old type 2 diabetes with a pre-obese BMI, with hypertension, and his values are there at 6.3, 135, 6.3 HbA1c, fasting 135, postprandial 220, and he's on OHAs. So since we've discussed here what should be the goal, and this is his diet recall. So as you go through the diet recall, and you can put it in the chat, what more information are you looking at? Ma'am, any inputs for you? How would you look at this case, and how would you take it ahead?
Yes, Geeta, you are right. So at this young age, we would also like to look at what is the the cause of the diabetes here. Yes, he is an obese patient. So if we take it, and then we will, when we do the screening, that will tell us about the recall. But the symptomatic, if is he symptomatic at this point with OHA, whether he has any symptoms, or whether he has symptoms because of his postprandial being high. So what are his hunger cramps, or what is his meal pattern? This is what you will want to see, and his medication, the timings, and how are you going to synchronize and achieve lifestyle management and bring down the weight. That is what we are looking at here, because if you see his HbA1c, it is 6.3, and it's quite good. We can see it is not even showing as the diabetic HbA1c, but because of his weight, and maybe because of his lifestyle, and he is having the hyperglycemia, or he is having the frank diabetes if you see his blood sugar levels. So these are the few things as we went through it, step 1, step 2, which we should include here, and the NCP process, the screening, and if any other thing the patient wants to share, whether he is having alcohol intake or any particular which is causing this blood sugar fluctuations, and the lifestyle, the activity, physical activity, and then you can take it further.
Next slide, please. True, ma'am. The first thing I think a dietitian do is interrogate the patient. Interrogate the patient on symptoms. As the slide doesn't show any symptoms to us, so we are really clueless that what it must be. So I left it to the audience to ask us that what may be the symptoms. So if the patient says, let's create a scenario saying that no symptom, as you rightly said, ma'am, asymptomatic. Just weight, height, BMI is what we have it, and he just has sedentary lifestyle, and that's what we're looking at, and he's just on OHA. So we all know it is lifestyle-induced hyperglycemia, which can be corrected through simple counseling, changing his diet and meal pattern, which can be worked. So I think the dietitians know that, okay, it's type 2 diabetes, already pathophysiology is in mind. Now the next step is ask the patient feeling tired, energy issues, ask the patient polyphagia, polydipsia, but it's not very high sugar level, so I think that also doesn't come into your mind. Then ask the patient that do you regularly test your sugar? Do you have a history of diabetes? So checklist. Your program should be having a checklist of asking the patient that what must have caused the diabetes. Genetics may be contributing, but he's just 35. So definitely it's lifestyle. And then take a recall. Anthropometry tells us BMI, biochemical tells us his lipid value. Clinically, he says, sorry, I have no symptoms. Maybe he may say, I have acidity, I have uric acid. We have not included all that, but scenario can be there in clinical. Dietary recall, you can now check that, okay, his volume of food is not very great, but maybe proteins are missing. Typical fiber intake and glycemic load can be worked on. And since he has a visceral fat, increased visceral fat, abdominal obesity, it may be a contribution of inactivity, and some glycemic load can be looked at in his diet. The next slide, please. So the dietitian's perspective, next slide. We should first work on making his waistline work for us, because that's the visceral fat area which may have contributed towards his hyperglycemia. Next slide. So I think this is how we start looking at his goals. Ma'am, any inputs here?
Yes, rightly said. You rightly put after we screen and after we put down our strategy or the goals, which is basically here in this particular scenario is the lifestyle change and the weight management. And whatever, you just can't say you stop drinking, but you can always reduce if there is the large amount of alcohol twice a week, and reduce the amount of the pack. And to work on the visceral fat, you can give a exercise regime to this patient, and then you have a follow-up, first follow-up maybe some 15 days or 1 month, and see whether he is complying patient, whether he wants to adhere to this, and how is he going to do. I think the choice of drug here from the medical fraternity will be metformin, which will also help into the aid first line management, aid into weight loss. So with whether he takes it, how much dose, and whether he takes it with which meal, and whether he has any symptoms because of the drugs, any GI symptoms that has to be tackled here. So basically here we are looking at the initial first line counseling, and then we will call the follow-up. You can add.
Absolutely. So I think we'll call off here, ma'am.